Now, protrusion. Now, how do you measure this? It's called protrusion. You bring the lower jaw forward, the anterior movement of the mandible, that's this. It's called protrusion. Now, this is guided by the facial surfaces of the mandibular incisors. You can see the mandibular incisors are guiding it. And it's the lingual surfaces of the upper maxillary. So you're basically bringing your jaw from here to this position. So they're moving, it's the lingual surfaces of the upper maxillary tooth, and you're moving the lower mandibular facial surface forward this way. And this anterior movement is called protrusion. Why is this important? When you do veneers and crowns, you want to make sure that you have a good amount of clearance. Because if you're not able to do this, and when you do this, you're going to notice at the back, your teeth do not touch each other. So when you do crowns at the back or fillings at the back, you want to ask the patient to do this. And you want to check and see if there are any teeth touching each other at the back. Because you want to restore the patient back to their closest normal that they walked in with. So when they walked in, they could do this. When they walk out, if they cannot do this, you have a problem. So you want to make sure that they are moving forward, and you want to make sure that the teeth at the back are not touching. And you want to record this movement and take pictures maybe, or you can also just take an impression, because when the patient leaves, you want to give them exactly what they came in with. So that's why this is important. Now, laterotrusion, like I told you, you can move your jaw to the side, this side, or this side. If you move it towards the midline, it's called mediotrusion. When you move it away from the midline, it's called laterotrusion. And you have to also be able to do these movements just like when the patient came in. Because after you do a crown or a filling, if they cannot make these same movements, then you have to adjust your occlusion. Now, various forms of guidance in laterotrusion. Now, when you have canine guidance, so what does that mean? When I do this, my top and bottom canines are basically touching each other. So when the top and bottom canines touch each other, and you can do this too in the mirror and see, that's called canine guidance. It means that the upper and lower canine, the teeth are guided out of occlusion through contact between opposing canines. So when the top and bottom canine touch each other, this is called canine guidance because it throws all the other teeth out of contact. Try it out. When you do this, all the other teeth are out of contact because just the canines are touching. What is canine segment guidance? Canines and the adjacent teeth guide arches out of occlusion. Some people have just one canine guidance. So for me, when I touch my canines, nothing else is touching. For some people who have a bridge, it's okay to make a bridge where the whole segment is touching because it's, based on their bite and how long they haven't had teeth. Sometimes you have to do something called a canine segment guidance where the whole arch is touching, not just your canine. Then group function. Group function is nothing but multiple teeth contact during laterotrusion. What does that mean? There's mediotrusion where you're moving your jaw towards your midline, and there's laterotrusion where you're moving your jaw away from the midline. And when you're doing that, multiple teeth are coming in contact during the laterotrusion. That kind of touching of the teeth is called group function, or multiple teeth coming in contact. Can you see this picture over here? When you're moving the teeth, this is coming in contact, this is coming in contact, so this is called group function. All right, so let's look at an example of lateral clinical guidance. As you can see over here, when the upper and the lower canine are touching each other, no other tooth is touching. So this is called canine guidance. You want to make sure that the patient is put back into this position. Now, in which direction is the mandible moving? In this case here, the lower mandible is coming out. It's coming this way. Okay, so it's moving away from the midline, or it's a laterotrusive movement. Okay, Now, which teeth are contacting? You can definitely see this one has some contact. This one has very minimal contact. No other teeth has contact. Now, I can't really tell in the picture. It looks like there's a slight gap here. It's just the canines that are in contact with each other. This is a picture of canine guidance because the canines are touching. Over here, the canines are not touching each other. So there's no canine guidance in this picture, but there is more a segmental, or the back teeth are touching. So this is more a segmental occlusion, where the segment is touching, but the canine is not touching. Okay, the mandible is moving to the right in both examples. Patient 1 has canine guidance. Patient 2 has group function. That's exactly what we spoke about. So in which patient would it be easier to do a crown? Obviously, when a patient, like patient 1, if you do a crown, he still has an opening. But in your patient 2, if you do a crown, you have to be very careful that the patient does not find that it's too high. Because the moment you do a crown here, this patient is going to complain to you that it's too high. All right, now let's talk about a quick summary. So every tooth has pathways based on the movements of the other tooth that's opposing it. For example, if you look at a lower molar. So this lower molar is the patient's lower left molar. So if you imagine this is a patient's mouth, right? You want to make sure that this is a patient's mouth, this is the patient's right side, and this is the patient's left side. So the molar would be sitting right here. So this molar is capable of what kind of pathways can be created with the motion of the upper. So you can have the lower jaw moving forward this way in protrusion, or you can move your jaw this way in laterotrusion, or you can move your jaw this way in mediotrusion. So these are the different types of movements the lower molar is capable of making. Now let's look at the upper molar. Now if you imagine this is the this is the upper molar in this arch. So this upper molar is able to move forward in protrusion. It can move this way towards the midline, which is mediotrusion, or the upper molar can move this way in laterotrusion. So each tooth is capable of these pathways. In the lower, you saw these pathways, and in the upper, you're seeing these pathways. So as you can see, the upper diagram, if you actually draw it, it's actually exactly opposite to what's happening in the lower. So if you observe, it's a mirror image of what is happening in the lower. So this is I just superimposed this into this, and you can see it's basically a mirror image of what is going on. So this is a quick trick for you to remember the movements. If you look at the lower molar, you can just draw it this way and remember that these are the movements happening in the lower molar. And if you do the exact opposite, like a mirror image, and that's exactly what's happening on the upper, you can remember the movements that way. So sometimes you can get a question like this on your board where they're asking you, which tooth is that? That is the lower second premolar. Okay, they're asking you, which quadrant is it? So if you look at the quadrant, you can possibly have the tongue, let's see. Yeah, this looks like the tongue is possibly over here. That's possibly your tongue. And these are your buccal cusps, these are your lingual cusps. They're asking you which tooth is that. That is this looks like the lower quadrant. It looks like the patient's lower right. And they're asking you the intercuspal contact, base of the arrow. So there's a contact right there, yes. So this tooth basically contacts the upper premolar. You're looking at the upper lingual cusp of the upper premolar comes in contact with this tooth. What type of pathways does this tooth generate? So this tooth can move It can generate a forward pathway, it can generate a pathway this way, and it can generate a pathway this way. And these are the three types of pathways this tooth can generate. And type of mandibular movement. What kind of movement is this tooth capable of doing? This kind of tooth can do a forward movement, which is a protrusive movement, or with the help of the opposing tooth, the pathway that it can, so the movement this tooth can do is a forward movement or a protrusive movement. But the pathways this tooth is capable of generating are three. It's a forward pathway, a mediotrusive towards the midline, and a laterotrusive pathway. Okay. Now, practice question number 2, arch and quadrant. It's the exact same same picture that you saw there. It's asking you the type of pathway, the type of mandibular movement. Is quadrant on the laterotrusive or the mediotrusive side? So which means that if this is the tongue here and this is the midline, if the arrow is pointing this way, this is a mediotrusive movement. So you're moving towards the midline. But if the arrow was pointing this way, then it was a laterotrusive movement, or you're moving away from the midline. So this is something you just want to remember. Paste this image in your head. You need to know which tooth comes in contact with which tooth in a picket fence like occlusion. So if I give you a picture of the upper premolar, you need to automatically know that it comes in contact with the lower two premolars. Or if I show you an upper molar like this, and I show you a picture of the lower molar like this, you need to be able to identify right away that this is a class 1 occlusion. And you also need to remember that these points, you need to memorize the different points that are made on the upper teeth and on the lower teeth. For example, this segment is the upper teeth and this segment is the lower teeth. You need to remember these points because when the jaw is moving side to side in mediotrusive and laterotrusive movements, these are the points that are generated. Occlusal interferences. We spoke about this. When you have a high filling, you're creating an occlusal interference. When the teeth prevent normal jaw function, the patient says, I'm having pain, I cannot close down, that's called an occlusal interference. There are 4 types of interferences. It can be incentric. When you're down like this, patient is saying, I'm feeling something high. Working means the side that is working. Or non-working, meaning the other side. So when this side is working, this side, the opposite side, becomes the non-working side. So it could be the patient is doing this, but they're feeling something high here. So you may have to go in and adjust that. Or protrusive. The patient is doing this, they're feeling that the crown is too high at the back because you did not respect the gap. So you want to check all 4 positions. 1, 2, 3, and 4. 4 positions you want to check. Now, what is normal versus pathological occlusion? Normal does not mean ideal because sometimes patients are missing teeth at birth. They're missing teeth, at the age of 5, they got a tooth extracted. So normal is whatever is normal for that person. When a patient cannot tolerate the interferences and adapt without pain, so if oftentimes you do a filling which is slightly high, sometimes you'll see the patient still is fine. How does that happen? Because the body adapts, the bite adapts, the pit and fissure sealant, automatically grinds down a little bit. So all these things is self-adaptive. But when a patient comes back with pain and you're adding stress to their TMJ or the joint or there's tooth wear, they cannot bear it, they cannot breathe, they cannot open their mouth, then you have caused a pathological occlusion. A pathological occlusion is something that is causing pathology or pain or discomfort to the patient. Now, optimal occlusion, Okeson very well defined. Optimal is whatever best occlusion you can give that patient for their normal functioning. You want to try to bring centric relation as close as possible to the centric occlusion. What does that mean? When a patient is biting down, you want to bring them in a position that is very close to their condyle being in their most posterior position. Axial loading of teeth, what does that mean? You want to make sure that the upper and lower teeth are coming in contact with each other. That way the forces when you're chewing go through the middle of the teeth. That's called axial loading. Canine guidance, when you do this, you need the canines to touch on both sides as much as possible. Anterior guidance, when you do this, you want to make sure the anterior teeth are touching each other as well. Posterior contacts are heavier than anterior, always. When you check the blue paper, you want to make sure the dots at the back are heavier than the dots in the front. That's just, these are the rules of optimal occlusion that Okeson came up with. He said if you follow 1, 2, 3, 4, 5 things, the patient will not come back with any pain. So how do you organize everything you have learned? Everything we have learned so far can be organized into occlusion, can be broken down into bilateral balanced, unilateral balanced, and mutually protected occlusion. Bilaterally balanced means on both sides when you bite down, there is equal touching or balance on both sides. Sometimes when you do just this, that's unilaterally balanced, where only one side is touching and the other side is not touching. So let's look into this. So bilaterally balanced, like I said, is basically when you bite down, the bilateral simultaneous anterior and posterior occlusal contact of teeth in centric and eccentric positions. So there is simultaneous contact of upper and lower teeth in centric and eccentric. Off-centric is eccentric. Now, during lateral excursions, that means I'm doing this. One side there's not going to be contact because it's going to be open. Try it out. So that side where there's no contact is called the non-working side. The side that is working and that is touching is called the working side. So this is called a unilateral balance. There is still balance, but it's only on one side. That's because you have shifted your jaw. Now, mutually protected, what does this mean? When you touch the canine like this, all the back teeth are not touching, and sometimes the front teeth are also not touching. During lateral excursions, there are no contacts between the teeth on the mediotrusive non-working side. All contacts between the laterotrusive working side canines, all the contacts are just here. So what they're trying to say is when only this is touching, and nothing else over here is touching, and nothing else over here is touching, this is where it's protecting the occlusion. This is called as canine guided articulation or canine guided occlusion. So effects of determinants. Now, if you alter these basic laws where you create a crown that's too high, or you don't respect the condylar guidance, or you don't respect the anterior guidance, what is going to happen? Let's see. Molar disocclusion. Remember, even at rest, when we're just resting and you look inside a patient's mouth, there's always a little bit of gap between the teeth, and you want to make sure you're respecting that when you're making crowns. So the normal discrepancy, it's okay to have some discrepancy between these measurements. And what they're saying is in centric relation, 0.2 millimeters is allowed. On the working side, 0.3 millimeters is allowed. On the non-working side, 0.8 millimeters is allowed. It's important to allow enough room in the posterior teeth between the cusps to prevent clashing during functioning. Now, condylar guidance, remember I told you how you open. Some people have a very steep opening. That's this angle over here for some people is very shallow. So you have some people who have an angle like this, and some people who have, this is a steep one, and for some people it's more shallow. So depending on how their condyle slides in their jaw, that is also going to depend on how much they can open their mouth. So the steeper they can slide, the more they can open. The lesser that they slide, the lesser is their mouth opening. So depending on this, you also have to determine the height of the crowns that you are making. If you're making teeth with very tall crowns and a patient cannot open their mouth, you're going to have a patient coming back in a lot of pain. So if your condylar guidance is steep, like this, and the patient can open the mouth wide, this allows for increasing the height of the posterior cusps. And it's the opposite when it's shallow. Anterior guidance. It's very important that the lower incisal edges contact linguals. There's contact when you do this. Now the protrusive incisal inclination should be between 50 to 70%. Steeper the protrusive incisal path, the taller the posterior cusps may be. What does that mean? If you're doing this and you have a nice big fat opening at the back, then you can make your crowns taller. But when the patient is doing this, you're seeing there's not that much gap at the back. You cannot stuff in a very big crown or a very big filling over there. So this anterior guidance is always good to do before you start your filling. You tell the patient, can you guide your jaw forward? And look and see. When you look and see, and you can see that the patient does not have that much clearance, keep in mind you do not want to do really big cusps. You want to keep the cusp more shallow. Now this is what anterior guidance is. When the lower incisor comes forward like that, there should be contact between the anterior teeth like this, but your back teeth should have no contact with each other. So at the end of your filling or the crown, repeat it again. Tell your patient to do this and check that there's no contact at the back. Then you have done a successful job. And that basically, with that, I am going to summarize everything you have learned. You learned the different types of occlusion, different types of malocclusion. How does malocclusion affect the patient? What are the important things you look for when it comes to occlusion of the upper and lower teeth? What is centric relation? What is centric occlusion? What are the different types of movements the lower jaw is capable of doing? What is canine guidance? What is incisal guidance? Why is that important? What is working side? What is non-working side? What are the different pathways every tooth is capable of having when they move? And what are the importance of this in our real life? So this is everything that we discussed, and I look forward to seeing you on our Google Classroom chat today or our Google Meet, where we will discuss this in detail. Have a fabulous day and see you soon.